Great. Well, good afternoon. Welcome everyone to this UROLUTS educational platform. And it's a pleasure and honor to have with us today Professor Marcus Drake from Imperial College in London, who led a very impressive and completely packed session this morning on bladder outlet obstruction and bladder overactivity. And it's fascinating, lots of insights. So it's a pleasure to have you here with us today, Marcus.
Thanks very much.
So can you I mean, it was a great session. I really loved it. What would you say, it's a very complex group. We see all the time, men who have mixed LUTS, storage and voiding, and it's always that difficult decision of, okay, what should we treat first? How do you assess these men in clinical practice? What do you do to help guide decision making?
Such a classic scenario, isn't it? You've got the older man, he attends with a combination of voiding symptoms and storage symptoms, and he is looking for a solution, one intervention to treat both problems. So our discussion was really focusing on, can we really assert that there is a link between obstruction and overactive bladder? And it's a complicated discussion. There's not that much evidence on which to really base it. So we focused a bit on the epidemiology. Do you actually see that the male prevalence of overactive bladder starts to accelerate at the sort of age range when prostatic enlargement is starting to take effect? Does it accelerate faster than the age-driven acceleration of overactive bladder in women where prostate obstruction does not apply? So we reviewed that evidence and found that it's not consistent. Some signal, but enough to say the relationship is unproven. So we were considering about the pathophysiology, the mechanisms behind overactive bladder. Are any of them actually driven by enlargement of the prostate? And we looked at all sorts of possibilities, but when you really drill down on the pathophysiology of OAB, it's central nervous system, smooth muscle function. None of them are really directly affected by obstruction. And the one that stands out, the urethral receptors. Afferents in the urethra, when they get stimulated, send a very powerful urgency sensation. With an enlarged prostate, you could, of course, have occlusive lateral lobes, and that would stimulate the urethral afferents. Alternatively, inflammation within the prostate. And that is another mechanism that just possibly relieving the obstruction would reliably help overactive bladder. But how do you tell for an individual? And then our final line of evidence is the response to interventional treatment. Does overactive bladder truly improve? And again, it's not a clear picture on that one. And indeed, there are predictive factors that would say overactive bladder or detrusor overactivity does not improve if the severity is significant, like maximum systomatric capacity of 250 mils. So in conclusion, we'd have to say that great care is needed, very honest approach to your patient, that it's hard to anticipate, that being certain that things won't be bad is not possible, and that they need to be prepared for a risk that actually sometimes symptoms might get worse after interventional treatment in terms of the incontinence.
Yeah, absolutely. No, I completely agree with that. And it's very interesting, I saw in your talk as well, you mentioned it just now about these predictive factors. And you mentioned one potential looking at bladder capacity or a limitation of 250 mils. Is there anything else you typically look at, either urodynamically, like the presence or the severity of DO, or even other symptom scores, or anything else that you look at that would either lean you more towards treating the OAB first, or vice versa, more towards treating the prostate, or thinking that a patient will get a good outcome storage-wise from treating the prostate?
Well, I think it's not one individual thing, it's the full picture, the full scenario. You must be very careful to get a proper symptom score completed by the patient. And it should really be one where you're being told the severity of each individual symptom, but also the bother related to that symptom. That is vital because men who are not bothered by voiding symptoms tend not to report improvement if you did the interventional treatment. So bother and severity have to be captured. So along with the urodynamic parameter of maximum cystometric capacity, you'd add severity of detrusor overactivity, and you'd put it into the context of a symptom score, which is telling you about the severity and bother of individual symptoms, preferably with a nice clear bladder diary where you're seeing 3 days worth, day and night recorded on continuous successive days, where you're seeing how often are they getting urgency, what is the typical voided volume, what is the maximum voided volume, is it more daytime than nighttime, and this whole package is vital.
Yeah. In terms of the symptom questionnaire, a lot of people use IPSS, don't they, kind of historically, and it's still used widely, and it's very prostate focused. Is that the tool you use most commonly, or do you use one of the ICIQ questionnaires?
It's interesting you say it's prostate focused. It's only prostate focused in the name, and it's a stupid name. And I'd say that without any compunction. It's a stupid name. Because as soon as you say International Prostate Symptom Score, the patient thinks, doctor is blaming my prostate. Doctor, deal with my prostate. And all the effective assessments do not pejoratively claim bladder or prostate or whatever it is. They just simply say lower urinary tract symptoms. And that way, you're not ascribing a mechanism which biases patients, biases doctors, and encourages interventional treatment. So IPSS, the name is bad. It's also incomplete because it doesn't discuss incontinence or post-micturition dribble. Its bother score, well, it's a good bother score for the overall picture, but it does not tell you about the individual symptoms. So you've got to ask which is bothering you more. And then the other thing, I always try to advise people to read the questions in the IPSS. If you go and read them, you'll find they're not very clear. And our patients are sort of like, I think it means this. It's not reliable. Basically because it was developed by adult urologists many years ago, so all male, and all just sat around a table saying, hey, we should ask about this. And that's not how you develop a proper questionnaire by modern technique. Nowadays, it's how does the patient word it? By asking the patients and making sure that it's developed properly. So the ICIQ score is the one that I use. There is a male LUTS one, and that's what the upstream study used for predicting outcome. The voiding subscore of the ICIQ MLUTS is the predictor for successful outcome from surgery. And then there is an ICIQ for female LUTS as well. But now ICIQ has actually recognized that in the modern era, we need to deal with the non-binary population and not offend them by giving them a male or a female. That is problematic for non-binary. So the two are being combined, and we're testing an ICIQ LUTS.
Wow, okay, great. Well, good to hear.
Yeah.
And so how, now, if you were trying to get more evidence in this area, or designing a trial to really help us answer a bit better, whose overactive bladder is related to the obstruction, or who's going to improve after relief of obstruction, what kind of trials do we need in this area? What kind of study do we need to do to get the evidence for this?
Well, you do want a before and after. And of course, the International Continence Society BPH study was very good for urodynamics before and after. And the urodynamics was done within the package of full assessment with symptom scores and examination and history and the like. So that study, well, to be honest, we should be going back to look at that and revisit the conclusions and really highlight, because I think actually there is already significant knowledge here. Where we're rather lacking is the implication of a minimally invasive surgical treatment. The mists, the thinking behind, the decision making behind this is different in many practices from TURP, which is complete resolution of the outlet obstruction.
Yes.
Here, it's more about trying to achieve adequate outlet recovery whilst also avoiding harmful effects on sexual function, for example, or prolonged recovery or catheter use. Now, the overactive bladder sort of fits into this wider picture of what matters to the patient is the overall quality of life. And so I would be rather keen to see in updated research getting the full pathway to include the values and preferences priority that you first authored on for European urology. This is such a fundamentally important thing that to merge the values and preferences document in the MIST era using a pathway which is informed by our upstream experience, testing before and after intervention, then we'd have a lovely landmark study.
Yeah, excellent. I mean, that's a great point about the MIST. You're right, that's where the evidence is really lacking. But Professor Drake, it's been an absolute pleasure to have you. Great session this morning. Thank you so much for your time joining us.
Likewise.
I hope you've all enjoyed the session, and I hope you have a good Congress.